Hi, my name's Bonnie Flemister. I want you to know that I'm a geriatric nurse practitioner, and what that means to you is that I know what you do. I actually have gone into nursing homes and worked with staff to help you take better care of your residents. What we're here for today is to talk about medication errors, and this is really important because between 10 and 18% of hospital injuries are attributed to medication errors. There are about 44,000 to 98,000 people die in the United States hospitals annually due to medication errors. Do you realize that means it would be the same as everybody in Marshall, Henderson, and Carthage, plus all the people that live in between being killed in one day? It is the third leading cause of death in the United States, just behind heart attacks and cancer. So if you could just imagine a fully loaded Boeing 747 airplane crashing every day of the year with no survivors, then you can begin to understand the number of preventable deaths that occur in our healthcare system. Now, if you knew that there was an airplane going to crash every single day with 500 to 600 people on it, you'd be a little afraid to fly, wouldn't you? Well, you need to be also considering being admitted to a hospital or having somebody you love being admitted. We're here today because state came in and tagged you with an F-333. And what that means is in order to be free of that tag, you have to show that residents are free of any significant medication errors. A medication error is a preparation or administration of a medication or biologicals which are not in accordance with either the doctor's order, the manufacturer's specifications regarding the preparation, administration of the medication or biological. That's on one of the things that's asked on your test. Or 3, the accepted professional standards and principles which apply to you providing your services or how you give meds and how you're responsible for that. What is a significant medication error? Well, it's one that causes the resident discomfort or jeopardizes his or her health and safety. The criteria of whether it's significant or not is based on expert opinion, whether it's a non-significant error or a significant error. And the expert opinion is the surveyor who comes into the building to decide whether or not it causes a significant injury. Usually, these things are considered significant medical errors. Those errors that require discontinuing a medication or modifying the dose, changing the dose, anything that requires hospitalization, anything that results in any kind of disability, anything that requires a treatment with another prescription medication, or results in some kind of cognitive deterioration or a change in the way the resident thinks, if they're life-threatening or if they result in death. We're going to talk first about hypoglycemic errors, and what I want to remind you is that hypo means low. So someone who has low sugar in their blood. There are 97,648 emergency room visits each year, and a third of those visits require hospitalization. You also need to remember that insulin-treated patients who are 80 years or older are twice as likely to visit the emergency room and nearly 5 times as likely to be hospitalized. Your responsibility as a nurse is nurses, we are responsible and liable for our actions and admissions, not just what we do, but what we don't do, and for those duties that we delegate to others. If you delegate an intervention to somebody else and they do it wrong, you're just as responsible as the person who did it. We are also personally responsible legally, morally, and ethically for every drug that we give. What you need to remember about diabetes is it's treatable, but there is no cure. There's actually two types, a type 1 who doesn't produce any insulin at all, and a type 2 produce some insulin, but not enough to meet their needs, or they have cells that resist and don't respond normally to insulin. Type 1 usually occurs in young people, children, and young adults, and type 2 is in the older adult. Here's something that really bothers me. I found it when I was preparing for another in-service on diabetes. But of all the children that were born in America in the year 2000, 1 in every 3 will develop diabetes in their lifetime. And this really came home to me because I have a granddaughter who was born in 2001, and I went to one of her little deals in her school, and I looked in her class and counted 1, 2, 3. That one's going to get diabetes. 1, 2, 3. That one's going to get diabetes. Insulin's a hormone that's produced by the pancreas, and the pancreas is located in the abdomen where your liver and gallbladder are. And that pancreas is necessary for the cells to be able to use the blood sugar. Insulin is secreted by having extra blood in, or any blood increase in in glucose in your blood. There are also some gastrointestinal hormones that increase insulin production. And then beta-adrenergic stimulation, which is when you start getting frightened or get stressed. An elevated blood glucose usually results in the secretion of insulin, and glucose is transported to the body cells. And so here's what happens. You have glucose in your blood, and then you get excess glucose in your blood, and then insulin is released from the pancreas when that sugar appears in the bloodstream, and then the hormone, which is insulin, takes up the glucose just like it's on a bus and transports it to the organs to be used for energy. The benefits of insulin therapy are because it helps prevent kidney damage, blindness, nerve problems. Remember, your diabetics have neuropathy in their feet. Amputation. Diabetes is the #1 cause of lower extremity amputation in the United States. There's also sexual function problems and increases heart attack and stroke. Some of the adverse effects, the most common is hypoglycemia, not having enough sugar in your blood because of too much insulin. Lipodystrophy, which is a lumping up of fat cells because we don't change sites and keep giving insulin in the same places. Sometimes at the beginning of therapy you have bilateral blurry vision, and why that causes. If I had a glass of water, you could see through the water, but if I put sugar in it and stirred it up, it would make the water cloudy and you couldn't see as clearly through it. And that's exactly what happens in your eye. Your eyeball is full of fluid, and when you have excess sugar, it's the same as looking through a glass of water with sugar in it. You can also get hypersensitive or allergic to where the needle actually goes in. There's weight gain associated with the beginning of insulin, and of course GI distress, but that often goes away after your doses are regulated. Can also cause an increase in heart rate. There's different types of insulin. They're classified by how quickly they work, how long their effects last, which is the duration, and when do they peak. Okay, because once you get a injection of insulin, the amount of insulin is spread over time in your body, and the point that it has the most is called the peak time. There's 3 types of insulin, which is basilar, which is like Lantus, MPH, and Livermore, and you should never hold those. I'm talking about if you get an order for an NPO, because your liver continually makes small amounts of glucose. Propranolol is Novolog and Humalog, and they're ordered with meals, and so their only job is to cover what extra sugar goes into the body in a meal. So if somebody is MPO, that would be held. And a correction or sliding scale is just a response to too much sugar, so those two would be held. You should always check blood sugar. If it's elevated, you give it. Basal insulin is background insulin. What I mean by that is it keeps the blood sugar stable during fasting, which is between meals or while you're asleep. Basal insulin helps to keep levels of the glucose in check as level as possible, and it reaches the bloodstream several hours after injection. It remains in the system for 18 to 24 hours, depending on which brand it is. There's long-lasting insulin. Lantus is up to 24 hours. Levemir lasts 24 hours, so 1 to 2 shots is required daily. And then Tresiba is more than 42 hours. Intermediate insulins are MPH, and they're generally injected twice a day. And they peak in 4 to 12 hours. And they're often combined with another short-acting insulin. The other short-acting insulins are rapid-acting, and then other short-acting insulins, which would be your regular insulins. This is a little graph to show you how the different insulins work. You can see that it's how fast they start, what their peaks are, and what the duration is. Pre-mixed insulins come in specific amounts of intermediate acting and short acting insulins in one bottle, or often in an insulin pen. The numbers following the brand name indicate the percentage of each type. So Humalin would be 70-30, would be 70 units of intermediate and 30 units of short acting. These products are generally taken 2 or 3 times a day before mealtime. The dosage. How does the doctor figure out how much insulin to give? The factors they consider are the lifestyle. Is the person sedimentary or active? The body's insulin needs. Remember, we all need different amounts of insulin, and depends on how our body reacts to it. Willingness to inject, and then morning blood sugar levels. Type 1 diabetics often require less insulin because they have a constant need, because you need to replace all of the body's insulin. Type 2 diabetes, they're insulin resistant, so they require more insulin. And then the basal insulin program is usually recommended when oral medications are no longer sufficient. And you've seen that as a diabetic is newly diagnosed and you start them out on a pill, and then that no longer works and they need to be switched over. They're based on weight, hormone levels, and diet. A lot of times the symptoms are not controlled, so they have to use a Baylor bolus, which is they have a baseline basilar insulin and then boluses in between to keep their levels. This is interesting. The American Diabetes Association put out new standards of medical care this year in 2017, and if you look and see that the recommendations, there's a lot of them, that they suggest that if you are on multi-dose insulin or you have a pump, you should do your blood glucose monitoring prior to meals and snacks, at bedtime, prior to exercise, when you suspect your blood sugar is low. After treating low blood sugar until you're sure that you're normal again, then prior to any critical tasks such as driving, and then occasionally after meals. That's a lot of testing. Why do we check blood sugars? Well, blood sugar levels may vary. Monitoring lets you know how the resident reacts to different situations in their routine. You need to report those results to the doctor so the ranges for each patient can be made based on your facility policy. And I understand that that your policy, that's a mistake. It shouldn't be more than 60. It should be less than 60 and more than 350. All the residents' blood sugar readings are important, and any result you get is good information and helps the doctor regulate their insulin dosage. So how does your checking your blood sugar levels help? Well, it helps the doctor determine the right dose. That's the doctor's responsibility, is the dose. Ours is to give it the way it's ordered. It also allows a dietitian to create a meal plan that works for the resident's lifestyle, and it helps decide when snacks are needed. And then the doctor can use those readings to create a new or sustain the orders that he's already written. Glucometer checks. You always review and follow Briarcliff's policy regarding the glucometer scales. You need to complete the necessary assessments or vital signs and document on the MAR and chart if needed. You need to determine if the test requires special timing, for example, before or after meals. And then blood glucose monitoring is usually done prior to meals and before the administration of any anti-diabetic medication. You need to record the dose, the timing, and the site of the injection on the MAR and initial and chart. The complications of insulin is hyperglycemia, too much sugar in the blood, and hypoglycemia, meaning too little. Hyper in Latin means high, hypo means low. So a little mnemonic is hot and dry, the sugar's too high, cold and clammy, they need some candy. The signs of hyperglycemia are pretty standard. Polyphagia, which means they're always hungry. They have blurred vision. Remember the fluid in their eyeballs. Polyuria, they're having to go to the void frequently. Tired, often thirsty, with weight loss. And the reason why they have weight loss is because the sugar is in their blood and it's not getting to the cells. Other symptoms might be poor wound healing. As you know, diabetics have a harder time healing their wounds than people who are not diabetic, having a dry mouth, dry itchy skin, impotence in a male, and then recurrent infections such as vaginal yeast infections or groin rashes. And we know that with our female diabetics. So here's a little cartoon, high blood pressure. What are the symptoms? Thirsty, weight, feeling tired and like you're carrying around extra weight, having to go to the bathroom. The reasons for hyperglycemia is you eat too much food or the wrong foods, sneaking around to the vending machine, exercising too little, physical stress is an infection, and you all know that you've all had diabetics that got for instance, they got a urinary tract infection and their sugar started going high. Emotional stress such as family conflict or workplace challenges. I told you that 1 out of 3 kids are going to have diabetes. I'm sure that sitting in this room right now are diabetics, and you need to know that emotional stress and problems in your family and workplace problems can cause your sugar to go high. And then problems with the insulin itself, such as not giving enough insulin or using expired insulin. Those of you out in the community, you need to pay attention to your loved ones and your relatives that take insulin, because they're not as apt to watch and see when that insulin expires. And remember, one of the problems with being diabetic is you can't see well, and the printing on those bottles is very small. Increased risk from hyperglycemia in the elderly in particular, it increases dehydration, and we know that we have a hard time getting them to drink enough water anyway. It impairs their vision and often makes them their cognition where they're not functioning the way they usually do mentally, and then the increased risk of infection. The causes of hyperglycemia in the elderly, the first one, of course, is polypharmacy. And what polypharmacy is anybody who takes More than 5 drugs is considered to have polypharmacy, and I know that you probably don't even have a resident in here that is on less than 5 medicines. Functional disabilities, common geriatric syndromes, cognitive impairment, dementia, depression, urinary incontinence, and then persistent pain. 80% of nursing home patients have chronic pain. The signs of hypoglycemia. Every single one of you has had a low blood sugar at some point in your life, where you've skipped breakfast or you didn't eat enough lunch and got home too late to have dinner, and you felt nervous and sweaty, and you were really, really hungry, and you got trembly and weak, and your heart started beating real fast, and you might even had trouble speaking. If you really have low blood sugar, you'll start getting confused and unable to complete your routine tasks. Of course, you'll have visual disturbances, and then, though uncommon, people whose blood sugar goes low enough may have a seizure. The increased risk in the elderly is you need to know that every older person in this nursing home is more vulnerable to hypoglycemia than people out in the community. They have more neuropsychopenic symptoms such as dizziness, weakness, delirium, confusion. And the problem is they start showing that weakness and confusion, and we seem to think they're having a stroke or a TIA when it's just simply a problem with not enough blood sugar. They can also have increased cardiovascular events. Unfortunately, if they have low blood sugar enough that they're required to go to the hospital, they have an increased risk of developing dementia, and if they do have dementia, it gets worse in repeated episodes. Hypoglycemia, they're at a higher risk if they have decreased renal function, and you need to remember 80-year-olds have 80-year-old kidneys. Not enough water, not enough hydration. They are all going to have slow intestinal functioning and being able to absorb the sugar that they do eat. And then there's always a concern for increased falls. If they're feeling weak or they're feeling dizzy, their risk for fall increases. The elderly glycemic goals. This is something that I learned when I was getting ready to do this program for you. I always thought that letting an 80-year-old's blood sugars run 200 was harmful, but their blood sugars running 200 was harmful. But I've found out that if you have a fit older population, I mean people who are out in the community or who exercise and walk, their glucose levels should be between 140 and 150 with an A1C goal of 7.5. Now that would be troublesome if in a 20-year-old. Medication treated with medical and functional comorbidities. That means any resident that you have that's on medication with a life expectancy of less than 10 years, their A1C, it's okay if it's 8.5, and their blood sugars, it's okay if they run 160 to 170. And you're very old, and that would, and old is not just age, their A1C, it's okay if it's less than 8.5 and their average glucose reading is 200. And that would be to preserve their quality of life and avoid their hypoglycemia. You know, we talk about the right response. We talk about what the rights of giving medications, the right patient, the right dose. But one of the things we need to pay attention to is the right response, and the only way to know that is to observe it. Once a medication is given, the nurse should monitor that patient to see if the medicine's doing what it's supposed to do. It also involves evaluation of the effectiveness. Not only is it doing what it's supposed to do, did it do a good job of doing what it was supposed to do? And that's really critical for some high-risk medications such as blood thinners, heart medications, and especially insulin. You need to monitor for the right response, for example, an assessment of the patient's blood glucose level or other vital signs and parameters. For instance, if you give a diuretic, did it work? Is the resident voiding? This is interesting. In a study of adverse drug events among older patients, inadequate patient monitoring after the medication was given occurs in 36% of the adverse drug events. That's one of your test questions. Okay, so we need to remember that part of the medication errors and not just giving the medication, it's monitoring after you give the drug. Physician notification. We know that there's two kinds of notification. One, you better call them right now and inform them just as soon as the event occurs, either directly or by beeper or phone call. Non-immediate is they should be informed of the problems during office hours and generally no later than the next office day. A change of condition, okay. Any glucometer reading immediately if it's less than 40 to 60, and anything over than 350, unless you've got parameters that cover you otherwise. And then I had non-immediate, anything consistently over 200, but remember we need to take into consideration the age of the patient and how healthy they are. A change in condition. I want to remind you that any alteration in mental status, you need to pay attention to it, and immediately if there's a sudden change in the mental status. So you need to accurately and completely report and document. Document. How else do we get to show what we've done and what needs to be done? We need to document the resident's status, including signs and symptoms. You have to document what you did. If you don't write down what you did, it looks like you didn't do anything. You need to pay attention to the physician's orders and make sure that those are documented. You need to pay attention to how you administered the medication or any treatments, and then for heaven's sakes, you need to document the patient's response and the contacts with any other healthcare members considering significant events. So if you have a problem and even though you've done what you could about it, you still need to tell the other members in the team what's been done and have them follow up. Physician also has duties. They need to participate in the resident's assessment and care planning, and they need to monitor changes in the medical status. And of course, the only way they're going to be doing that is for you to keep them up to date. They need to review the resident's total program of care at each required visit. It used to annoy me. I used to say that there's some doctors who do tonto visits where they stand at the doorway and look in. Prescribe new therapy and treatments as needed. The doctor needs to decide on the basal bolus ratio if any part of any diabetic treatment plan. They need to order the resident's transfer to the hospital if you tell them that they need to go. They need to supervise everybody who works with them on follow-up visits, and they need to provide consultation or treatment when they are called by your facility or by you, and they need to record the resident's progress and problems in their progress notes. Physician notification, you need to call the doc anytime there's a sudden or marked adverse change in signs, symptoms, or behavior, any unusual occurrence involving the resident. Of course, we know that if there's a 5-pound weight gain or change of 5 pounds in more than 30 days, if they respond in any unusual way to a medication or a treatment, if you have given them a life-threatening medication or there's been a treatment error and a threat to the resident's health or safety caused by your inability or the facility's inability to get or to administer prescribed drugs, equipment, supplies, or services. I've gone over the way you put in orders in the computer. If you have any questions about this at all, please ask your DON or assistant DON. You have a complete order detail box with all the information that you need to give a medication. I want to thank you for your time and your attention, and now it's time to take your post-test.